Emergency Anesthetic Management of Ruptured Abdominal Aortic Aneurysm. Hello, my name is Haitham Mekkawi, and today I'd like to welcome you to the battlefield of vascular catastrophe. When the abdominal aorta gives up under pressure and ruptures, we anesthesiologists must respond with speed and precision. Our goals? Prevent further blood loss, protect the heart from afterload injury, and avoid excessive fluids that might dislodge clots. This is not your routine case. This is controlled chaos in a sterile room. Before surgery begins, our mission is to maintain a fragile hemodynamic equilibrium. We must avoid excessive fluid administration that might disrupt the retroperitoneal tamponade, yet support perfusion enough to reach the operating room. A mean arterial pressure of at least 65 millimeters of mercury is our Goldilocks zone, not too high, not too low. And remember, speed matters. This is a race against time, not a marathon. You are summoned urgently to a ward. A 74-year-old gentleman with a known abdominal aortic aneurysm has collapsed, pale, diaphoretic, hypotensive, and gasping. The vascular surgeon is sweating almost as much as the patient. Your job? Think fast, plan faster, and act like your badge says Time Lord of Hemodynamics. This is not an exam question. This is real. And the patient's life depends on your decisions in the next few minutes. Understanding the pathophysiology. Clamp the aorta and watch the pressure soar. Release the clamp and welcome chaos. Aortic cross-clamping causes a spike in systemic vascular resistance, myocardial strain, and pulmonary pressures. Remove the clamp and the floodgates of lactate, acid, and potassium open, leading to hypotension, arrhythmias, and potentially coagulopathy. It is a hemodynamic roller coaster, and you're riding it without a seatbelt. Tamponade physiology in ruptured abdominal aortic aneurysm. In some lucky patients, the bleeding is self-contained, thanks to the retroperitoneum acting like a surgical tourniquet. But this delicate tamponade can be disrupted by anesthetic induction, muscle relaxation, or even positive pressure ventilation. Handle this clot like it's the last cupcake at a party, with care and reverence. Disturb it, and the bleeding restarts. Goal: directed resuscitation. Gone are the days of flooding the tank. Resuscitation is now about precision. Small, targeted fluid boluses, early vasopressors. And your endpoints? Look at the brain, the kidneys, and the capillary beds. This is a perfusion puzzle, and you must put the pieces together without causing dilutional coagulopathy or abdominal compartment syndrome. Monitoring strategy. Know your battlefield. Start with the basics: electrocardiogram, oxygen saturation, non-invasive blood pressure, and carbon dioxide monitoring. If time allows, insert an arterial line before induction. If not, place it afterward. You'll need temperature probes, urinary catheters, nasogastric tubes, and of course, the mighty level 1 infuser. This is a full surveillance operation. We're not flying blind. Challenges across phases. Resuscitation. Before you even enter the operating room, you face a minefield. Fluid too fast. You dislodge the tamponade. Delay to the theater. The aneurysm pops. Consent. Cross-match. In this phase, the anesthetist becomes triage officer, trauma leader, and sometimes therapist for everyone else panicking around you. Intraoperative challenges. Anesthetic induction is like lighting a match near a gas leak. The aorta may rupture further. Blood pressure crashes. Heart screams. Once cross-clamped, the pressure surges. When the clamp is removed, say hello to acidosis and hypotension. Meanwhile, you're running a transfusion marathon and checking clotting like a laboratory ninja. And please, choose your muscle relaxants wisely. Succinylcholine is not your friend today. Postoperative challenges. Surgery is done, but the fight is not over. Kidneys may shut down, the heart may protest, and the gut may swell with deadly pressure. Reperfusion injury and systemic inflammatory response lurk in the shadows. Ventilation continues, vasopressors flow, and the ICU becomes your theater of war. Vigilance is your only weapon now. Phased anesthetic strategy. Preoperative phase. Before surgery begins, take control. Oxygenate. Secure access with 2 wide-bore cannulas. Start vasopressors, not fluid floods. Cross-match blood like you're opening a vampire buffet. And for goodness sake, do not delay for computed tomography unless the patient is rock stable and endovascular repair is in the cards. Phased anesthetic strategy. Intraoperative phase. Your induction should be smoother than jazz. Etomidate or ketamine will give you hemodynamic grace. Rocuronium, no fasciculations, no drama. Once you're in, use inhalational or intravenous agents, but avoid nitrous oxide. It's about as helpful as a parachute made of paper. Monitor everything, gases, temperature, electrolytes. This is where preparation meets pressure. Think of the aortic clamp as a hydraulic disaster switch. When it goes on, systemic vascular resistance rises and the heart groans. When it comes off, you get a flood of acid and potassium. Manage each stage like a crisis in itself. Deepen anesthesia, use vasopressors wisely, and treat coagulopathy based on actual numbers, not vibes. Phased anesthetic strategy, postoperative phase. Now we're in damage control. Transfer to the intensive care unit, keep sedation going, and target that mean arterial pressure like your reputation depends on it. Monitor lactate for tissue perfusion, urine for renal function, and lab values for organ systems, trying to decide if they want to play nice or not. Common complications? Congratulations, your patient survived. Now let's talk about what could still go wrong: myocardial infarction, acute kidney injury, abdominal compartment syndrome, and spinal cord ischemia. It's like playing Jenga with organ systems. Pull the wrong block, and everything collapses. Here's your cheat sheet. One page to rule them all. Preoperative, balance fluid and prep. Intraoperative, avoid hemodynamic Armageddon. Postoperative, stay alert, stay in ICU, and monitor like a hawk on espresso. Master this table, and you might just survive your next on-call shift. And if you think this video is good, make comment below to encourage us. Conclusion, this is not just another vascular case. This is a full-body emergency with seconds to act and lives at stake. You are the anesthetist, the calm in the storm. You hold the keys to perfusion, protection, and postoperative peace. So step in with confidence, caution, and a little caffeine. You are at the front line. Please don't forget to hit the like button and subscribe. Thank you.